So, good evening, everybody. This is a very special meeting tonight with the Padova Pancreas Club because I have the honor and the pleasure to introduce you to Professor H Katz, who is a world-known expert in the field of pancreatic surgery. And I ask Matthew to tonight introduce us to a topic I truly know in his heart, or better say in his pancreas, which is preoperative therapy for localized pancreatic adenocarcinoma. Dr. Katz leads the pancreatic surgery program at the MD Anderson Cancer Center of Houston, which is a center who paved the way in the last decades towards a shift in our mentality, not only in our surgical practice, towards neoadjuvant chemotherapy and the selection of patients who really benefit for pancreatic surgery. So I'm extremely happy that he is gifting us with his time to provide us with his talk. And so the title would be Preoperative Therapy for Localized Pancreatic Adenocarcinoma. So Dr. Katz, once again, welcome virtually to Padua, and thank you so much for being with us tonight, and the virtual podium is yours.
Thanks very much, Giovanni. It's always great to speak to my Italian friends, and it was great to see Giovanni in Portugal this past week, and I was really looking forward to speaking with you all today. So today I'm going to talk about preoperative therapy, perioperative therapy, really. So therapy before and after surgery. Three objectives of the talk. First of all, to review the role of preoperative therapy for localized pancreas cancer. Number two, to review some high-level clinical trials data that inform preoperative management, but I'm not going to give too much in terms of data. And then really want to focus on the conceptual shift that really is necessary for us to continue to make progress in the study of patients with this disease. So we know that patients with pancreas cancer are unfortunately rarely cured, but their survival can be prolonged with surgery, particularly when followed by chemotherapy. So these are a trial of, this was the Conco 001 trial. It was done in the early 2010s, and it randomized patients, all of whom had resectable pancreas cancer, to either receive observation after surgery or receive 6 months of gemcitabine chemotherapy after resection. And what was remarkable and the takeaway points from this study were two things. First of all, without chemotherapy, patients did really poorly. So you can see here the patients in the observation arm lived an average of not even 2 years. Okay, that's not recurrence-free survival, that's overall survival. So really most of the patients, about half of the patients in this study, didn't even make it to the 2-year mark. Gemcitabine-based chemotherapy did prolong survival, but frankly, not by that much. So the overall survival in the observation group was 20 months. The overall survival in the chemotherapy group after surgery was 22 months. So from this study, we learned that, number one, we confirmed that survival after surgery alone is poor. Number two, survival can be improved with postoperative chemotherapy, but unfortunately only by a matter of weeks. That was in the early 2010s, and things have certainly improved, at least to some degree, through the use of multi-agent chemotherapy instead of mono-agent chemotherapy. So several trials, all of which remarkably were from Europe, gave us new information in how to treat patients postoperatively. SPAC4 study, and then after the Conco 01 study, the SPAC4 study, and then ultimately the Protease 24 study, which was published in 2018. And that study, again, randomized patients who had undergone potentially curative therapy for pancreatic cancer to either gemcitabine or FOLFIRINOX. And in this study, patients who were randomized to FOLFIRINOX after surgery lived on average almost 5 years, almost 60 months. Now, interestingly, the overall survival of patients who received gemcitabine after surgery was also, prolonged relative to the group who received gemcitabine on CONCO-01. So there's probably been some improvements in staging and improvements in patient selection and all that stuff over the last decade or two. But the long story short is that the standard of care now, at least when patients undergo surgery de novo, is to receive 6 months of modified FOLFIRINOX after surgery. But there are some advantages to giving chemotherapy before surgery, and those are increasingly recognized. So giving chemotherapy before surgery instead of after it. Typically, when we give preoperative therapy for pancreas cancer, we're talking about 4 treatment modalities, really. Number one, chemotherapy, and the purpose of that is to destroy systemic cancer cells wherever they may be and to improve systemic control. So improve local control and systemic control. Radiation therapy is used in some centers and in some areas to sterilize the region, the postoperative tumor bed, or the operative tumor bed, and sterilize margins and improve local control, so reduce or prolong time to local recurrence or eliminate local recurrence. And then I think a really important therapy that kind of flies under the radar is actually time. So we can modulate the time within which the chemotherapy and the radiation is delivered to select tumors and patients who are most likely to benefit from resection and to reduce the likelihood of a futile operation. Historically, when we've administered preoperative therapy of whatever kind, we've then done pancreatectomy in the absence of disease progression because we haven't really had good markers for treatment response. And there's data to support the use of preoperative therapy, at least in the borderline resectable setting. So this is the PREOPANC-1 study, which you are likely aware of. It's a study from the Netherlands, which randomized patients with either resectable or borderline resectable pancreatic cancer to either undergo surgery first and then receive 6 months of adjuvant gemcitabine chemotherapy, or to receive gemcitabine-based chemoradiation first and then undergo surgery and then receive gemcitabine chemotherapy. The primary endpoint of this study was overall survival, and these are essentially the long-term results. When the study first was published in JCO, the study was negative. So in the comparison between the two groups, there was absolutely no difference between the median overall survival of patients who underwent surgery first and those who received preoperative radiation. But when they went back a few years later and looked at the long-term results from the data, they found that there was significant separation between the curves, and that long-term survival, measured by 5-year overall survival, was enhanced by the delivery of preoperative chemoradiotherapy. So patients who received preoperative chemoradiation therapy had a 5-year overall survival rate of 21%, whereas patients who underwent surgery first had a 5-year overall survival rate of 7%. So even though the median overall survival did not change, there was separation afterwards, which caused the authors to conclude that chemoradiation therapy preoperatively was beneficial. They also did some sub-analyses in their showed some sub-analyses in their paper, which showed that really the benefit to receiving preoperative chemoradiation therapy was largely in the borderline resectable group. So if you looked at the resectable patients, there was no difference. If you looked at the borderline resectable patients, there was an advantage to the receipt of preoperative chemoradiation therapy. But we know that there's also some data in the resectable setting that shows the advantage of preoperative therapy. There's some data from Japan in a study that was presented at ASCO several years back and has actually curiously never been published, which showed that patients who received preoperative chemotherapy, gemcitabine and S1, prior to surgery lived longer, much longer actually, than patients who underwent surgery first and chemotherapy. But then there's conflicting data in the resectable setting, because there was a study recently out of Scandinavia, the NORPACT study, which showed that patients who underwent surgery first actually live longer. So again, while the data in the borderline resectable setting seems to imply the benefit of preoperative therapy, the benefit in the resectable setting is less clear. But frankly, I would argue that it doesn't really, all this is kind of silly, because stage, when we're talking about patients with pancreatic cancer, to some degree is a meaningless construct, because it does not matter what we see on the CAT scans of patients with pancreas cancer. Most, if not all, patients have actually metastatic disease. So not borderline resectable disease, not resectable disease, not locally advanced disease. Pretty much everyone has metastatic disease. The question is, how much metastatic disease do they have? These are data here that I'm showing on this slide from a mouse model study from one of the gastroenterologists that works here at MD Anderson. And what he did was develop a fluorescently labeled mouse model of pancreatic cancer, in which the mice were genetically engineered to develop pancreas cancers over time. And because those pancreas cancers were labeled with green fluorescent protein, he was able to track pancreas cancer cells, not only in the pancreas as the tumor grew, but also in the circulation and within metastatic sites such as the liver. And what he showed was that you could identify cancer cells in the liver and in the bloodstream even prior to identifying macroscopic tumors within the pancreas, meaning they had metastatic disease even before they had primary tumors that you could see. So what that's telling us is that growth and progression of pancreas cancer is not sequential. It doesn't grow in the pancreas until it gets a certain size, and then one day, once it gets to a certain size, it moves on to the liver. What actually happens is it starts growing in the pancreas and immediately starts seeding other sites. And as it grows in the pancreas, it is also growing in those other sites. And that's why when we fixate on the pancreatic tumor and take it out, in most patients, we see disease recurrence shortly thereafter from micrometastatic disease that we just weren't addressing with surgery. The other issue is the other problem that we face as surgeons is not only do we have these microscopic cells floating around and in the liver, even when all we see is a tumor in the pancreas, but when we do an operation to remove the tumor in the pancreas, we're often left with tumor cells left behind in the tumor bed, either in nerves or in lymphatics. We know that cancer cells are very neurotropic. They infiltrate through the retroperitoneum and hide essentially in nerves. They're attracted to nerves, and they basically seek out the nerves and find the nerves and bury themselves in the nerves. And so, we can take out, what looks like a very small tumor, like this one here, and do a complete resection where we take out all of this other tissue around the relatively very small tumor and be left with positive margins, because the tumors are actually infiltrating through all of this tissue and getting into the nerves around the arteries And those are tumor cells that our knife cannot address as surgeons. So, this is the fundamental problem. When we have tumor localized, they're not actually localized, they're metastatic. And then when we try to take them out, we're left with microscopic residual disease, both floating around in the circulation, as well as left residual in the tumor bed. And what happens as we're recovering, as our patient is recovering from an operation, is they're not getting chemotherapy because we typically wait 6 to 10 weeks following operation to administer chemotherapy. And while we're waiting, the cells that are left are basically having a field day and growing and disseminating and further spreading. These are data from a paper that was published in Cell. It's pretty old by now, but I really liked it because they essentially use mathematical modeling of pancreatic cancer proliferation and metastasis and showed the effects of delays on chemotherapy after surgery. And basically, what they found was if you even if you treated with a chemotherapy after surgery that was 99% effective, and we know we don't have chemotherapeutics like that, but even if we were to do that, you're still going to get growth and recurrence following chemotherapy. Following surgery. And the less effective your chemotherapy is, or the longer your delay to therapy, the more rapid that disease recurrence is going to occur. And this is typically what we see, clinically. We operate on a patient who has a small tumor. We take out the tumor, everything looks great. The patient recovers very well. We congratulate each other and get all happy. And then, 6 to 12 months later, the patient has recurrent disease. And this is the fundamental reason why. We can measure the extent of metastatic disease at the time of diagnosis to some degree with this tumor markers, such as CA19-9. So this was a study from Germany, Heidelberg, I think, or maybe it was Munich, but regardless, from Germany, in which they took patients who underwent surgery, all of whom had resectable cancers radiographically, and all of the patients underwent surgery. And then they looked retrospectively at their survival, stratified by their CA19-9 level at the time the tumors were identified and diagnosed. And essentially what they found was that the higher your tumor marker, the shorter your survival, to the point where even if these patients here in red had totally resectable cancers on their CAT scan, but CA19-9 is less than 1,000. Those patients had a median survival of 11 months, and you can do better with, arguably without an operation with systemic chemotherapy alone. So what these cancer markers are telling you, and CA19-9 is one such cancer marker, is telling you is essentially the burden of micrometastatic disease that exists. So we shouldn't really be about in terms of, localized or metastatic or, resectable, borderline, locally advanced, all this stuff. It's all kind of made up because at the end of the day, all these patients, or at least the overwhelming majority of patients, have metastatic disease, whether it can be identified or not. The other thing we have to consider from a surgical perspective is the physiologic profile of the patients that we're treating. It's all well and good to say that we will operate on a patient and then give them postoperative therapy, but we have to remember that many patients that we treat, at least in Texas, are not well when we see them, and they can't make it through an operation for one reason or another, or maybe they can make it through an operation, but then we can anticipate that they'll struggle postoperatively, and then they won't get their chemotherapy postoperatively. There are a number of reasons why patients, either won't do well after an operation or will do just well enough but then won't be ready to get their chemotherapy. Most of these patients are older, right? Median age of patients with pancreas cancer is 65, so half of our patients are older than 65. Many of our patients are frail. They may come in with malnourished, secondary to anorexia. Many of them have hyperbilirubinemia that causes them to be to not be hungry. They're sarcopenic due to catabolic proteins that are circulating. All these problems exist in many of our patients, and it really doesn't matter what the stage of your cancer is if operating on that patient would lead to morbidity. We actually use preoperative therapy and the time within which it is administered to put people through a prehabilitation program. So all of our patients are seen by physical medicine and rehab. They get baseline measures of their physiologic status and their functional status, such as their 6-minute walk and their 5 times sit to stand and grip strength and all these things. And then we put them on an exercise and nutrition program so that they can essentially become stronger and more fit prior to surgery. And giving the chemotherapy or radiation or whatever you're giving preoperatively allows a period of time within which to buff those patients up. It also gives time to completely evaluate a patient's comorbidities and optimize a patient's comorbidities. For example, if they have heart issues that require stenting or CABG or what have you. I just had a patient actually on Monday who initially presented a couple of months ago with a very resectable cancer in the tail of the pancreas, but had very significant peripheral vascular disease and actually and an abdominal aortic aneurysm. And actually, we treated that patient with preoperative therapy and got his aorta stented, and then I did his operation after a couple months, and he's doing quite well, 83 years old. So, this time period within which preoperative therapy is administered allows us to improve patients' physiologic status prior to surgery. So we put this all together in kind of the MD Anderson staging system, this ABC system. Now, I guess it's been we wrote it as part of an ISGPS paper a couple of years ago, and now it's ISGPS has also signed on to this. But it's not very there's nothing terribly genius about this system. It's basically saying don't necessarily only worry about tumor anatomy as dictated by the CAT scan, but you also have to worry about, what is the anticipated natural history of the cancer that you're dealing with, and what is the physiology of the patient in front of you. And the treatment recommendations that you should make are based not only on whether a tumor is resectable, borderline resectable, locally advanced, whatever, but on the anatomy, the A, the biology, the B, and the physiology or the condition, which is the C. And when we initially, put this out, and it's been 20 years now, and finally it's kind of catching on. But at any rate, when we initially put it out, we said C is more important than B, which is more important than A, meaning it doesn't matter what your anatomy is. If your biology is unfavorable or your patient is sick. So don't even worry about the CAT scan until you have a patient you can manage or a cancer that might be effectively treated by surgery. And I'm talking about surgical therapy here. In addition to the ISGPS, we also incorporated this kind of line of this strategy into JCO ASCO guidelines. So basically what ASCO guidelines say is if you have a patient who's healthy, has an anatomically resectable tumor, and CA 19-9 is normal, go ahead and operate on them. That's perfectly appropriate. It's also appropriate to consider preoperative therapy, but absolutely, and I truly believe this, if you have a healthy patient with a 19.9 that's normal, and an anatomically resectable tumor, I operate on those patients all the time. I have no problem operating on those patients. I think it's the right thing to do. Some of them I treat with preoperative therapy, and I talk about, the different potential advantages, but we don't know the difference between those two approaches. And the best data we have is in the setting of patients who have undergone surgery first. So if a patient meets all three of those criteria, I operate. Otherwise, if anything is off, I give preoperative therapy. If their tumor marker is high, if if their performance status isn't that good, if their anatomy is a little funky and it involves, arteries or a bit more than I would like, then I give preoperative therapy. And then you have to decide what that preoperative therapy is, but at least I use that opportunity to treat the tumor and the patient. So that brings a whole new set of questions. The first is, what chemotherapy do you give if you're going to treat in the preoperative setting? What do you treat with? This was a phase 2 study, an American study run by the SWOG Cooperative Group, where they took patients with anatomically resectable pancreas cancer and they randomized them to either receive perioperative FOLFIRINOX or perioperative gemcitabine and Abraxane. So half of the therapy was delivered before surgery, half of the therapy was delivered after surgery. And what they found was that the median survival of patients randomized to these two arms was basically identical. 22 months in the FOLFIRINOX group, 23 months in the gemcitabine and Abraxane group. So what does that tell you? It means that if you take 100 patients with resectable cancer and you want to treat them with pre-op therapy, it probably, the survival of the 100 patients is going to be probably the same whether you treat them with FOLFIRINOX or Gem-Abraxane. The question is, what will the survival of an individual patient be? And as I'll show you, there's reason to think that some patients may respond better to Gem-Abraxane than FOLFIRINOX and vice versa. And this study does not answer that question. It only answers the question, in a big population of patients. But all that being said, if you take all comers, FOLFIRINOX perioperatively, probably the same as gemcitabine and Abraxane perioperatively. And we have single institution data that is identical to this, and there's some multi-center retrospective data that's identical to this. All the data I've seen suggests that there's really no definite advantage to a population in the treatment with one over the other. What about radiation therapy? Well, the role of radiation therapy in the preoperative setting. Well, let me step back a minute. The role for radiation therapy in any setting for pancreas cancer, when you're thinking about cure or improving overall survival, is unclear. There is definitive data, and I don't know if there's any radiation oncologists on the call, but there is no definitive data that suggests its overall survival advantage for any population of patients treated with radiation. Whether that be locally advanced, whether that be resectable, treated postoperatively, resectable preoperatively, whatever. You can pick your group. But if you're looking at patients selected only by a shared anatomic phenotype, there's no advantage to that entire group of patients to radiation. And this was a study that we ran looking at the role of radiation in the borderline resectable setting. We took patients with borderline resectable disease, randomized them to FOLFIRINOX followed by radiation or FOLFIRINOX alone. And the long story short was that there was certainly no advantage to the radiation group. You could argue, I mean, the results were kind of funny, and I'm not going to go too into it. But suffice it to say that there was definitely no advantage to radiation. Now, again, like the gemcitabine, the SWOG study that I showed comparing the chemotherapy, where I said that you have to think about from an individual standpoint, an individual patient standpoint. All of these data show that radiation does not prolong survival of patients with pancreas cancer. Doesn't mean it doesn't prolong survival of an individual patient. And I definitely believe there are patients who benefit from preoperative radiation. There's also there's other endpoints that we need to consider when we're talking about radiation that we know radiation improves. Radiation in every study that's looked at it that I'm aware of has definitely improved local control and prolonged time to either local recurrence or progression. And those are not meaningless endpoints, right? I mean, it's important, when you're operating, uh, uh, there's benefit to having no tumor recurrence in the tumor bed. Patients who have tumor progression in the tumor bed and tumor recurrence in the tumor bed can lead to all sorts of problems, including, venous narrowing and thrombosis and arterial problems and biliary issues and pain and obstruction, all that kind of stuff. So there is advantage to local control, and radiation definitely improves local control. There's no question about that. So I'm not at all saying there's no role for radiation in pancreas cancer, but I am saying that if you're thinking about a group of patients selected only on the basis of their CT scans, the overall survival of that group is not going to be enhanced by radiation. So we have all these questions. What type of chemotherapy should individual patients get? How long should that chemotherapy be administered? Who should get radiation? What patients benefit from radiation and how? Which patients benefit from surgery? I'm a surgeon. I don't think many of my patients actually benefit from surgery. I'm the first to say it. And then how is response to therapy monitored? And that's when we have to start thinking not about patients in terms of disease stage or metastatic or what have you, and trying to treat everyone the same, but really trying to think about how to treat the individual, because there's an extraordinary amount of not only anatomic heterogeneity, but also genotypic heterogeneity and phenotypic heterogeneity in terms of pancreas cancer. It's not one single disease, it's many, many diseases in many different types of patients. And we can't establish one therapeutic standard for all those patients or even huge subsets of those patients. We really have to tailor treatments to the individual patient that we're seeing. Again, pancreas cancer is not a single disease. There's a complex mutational landscape that drives this disease. These are data from, on the left, the Cancer Genome Atlas, which looked at genomic alterations in pancreas, in resected pancreas tumors. And they found, the standard common alterations in things like KRAS and TP53 and things, but also alterations in genes that are actually targetable, like, for example, BRCA and PALB2, and now even KRAS. And these on the right are data that shows that if you treat patients based on a known marker or a known alteration with a treatment that is matched to that alteration when it exists, those patients do very well. So these are patients from PanCan, and they were stratified by whether they had a targetable alteration and received appropriate therapy against that alteration, or whether they either didn't have a targetable alteration or they had a targetable alteration but they were not treated with an appropriate therapy. And again, patients who were treated for targetable alterations with matched therapies did much longer. So it's really important that we think exactly about about the individual patient as opposed to necessarily what disease they have. This is a perfect example. We know that patients with alterations in BRCA1 are susceptible to PARP inhibitors. There's a whole class of drugs, PARP inhibitors, um, one of which is called olaparib. And this POLO study was a study that looked at uh, the value of olaparib in patients with pancreas cancer who had BRCA2 mutations. And essentially what it showed was that olaparib had a favorable effect, at least on progression-free survival of these patients. So olaparib, or um, uh, these PARP inhibitors, uh, uh, are actually pretty active, it seems, in patients with certain active. So the patient I had with multiple, who she initially presented to me with pancreas cancer and multiple liver metastases. You can see here on the PET scan. This PET scan actually understates the involvement of her liver. She essentially had, hundreds of liver metastases. Her liver was basically replaced with a metastasis. She had a CA19-9 when I saw her of 34,000, and she underwent EUS FNA of the pancreas that showed adenocarcinoma in a borderline resectable tumor in the pancreatic head. But interestingly, she also was found on her germline evaluation to have an alteration in BRCA2. So she was treated first with FOLFIRINOX, and she had a complete response based on her PET scan. And then she was treated with olaparib for several months, and her PET went completely cold, and her CA19-9 that was, 34,000 dropped down to the normal range. So I brought her to the operating room for a staging laparoscopy to do some liver biopsies. I biopsied several sites in her liver, and they were negative. I actually did not believe it, so I went back and did another staging laparoscopy on her and did another number of liver biopsies. Again, all of those were negative, and so I did her Whipple. And she ultimately recurred with pancreas cancer, and unfortunately ultimately died 2.5 years post-op. But that was ultimately, again, 2.5 years post-op. That's not too shabby for a patient who presented with a 19-9 of 34,000 and hundreds of liver metastases. She ultimately lived 4 years for a disease that, in the absence of a mutation, would arguably, kill her in 3 to 6 months. So, it's really important that we focus less on disease stage and focus on individual patients and characteristics of individual patients and tumors that might make us be more or less conservative or aggressive in a particular circumstance. Unfortunately, most patients with pancreas cancer don't have alterations that are targetable. About 7% of patients with pancreas cancer have a targetable mutation. So, while those stories like the one I showed you are awesome and are really exciting, the reality is that they're uncommon. But increasingly we're beginning to think not we're thinking about pancreas cancer not only in terms of specific alterations in specific genes, but also in the extent to which the cancer is expressing specific gene profiles. And so these are data, again, from the TCGA, in which they took 150 samples and they characterized levels of gene expression within these tumor samples. And they were able to identify broad categories of tumors based on the levels at which certain genes were being expressed. And there's lots of different categories, and I don't want to go too into it, but suffice it to say there's two main categories that we think about now: a classical subtype and a basal subtype. And the reason why these subtypes are important is because they have really important clinical implications with respect to treatment and response. So these are data from a study that was done in Canada, the COMPASS study, and there's been a lot of additional work in this area, but what these investigators did was they took patients who had locally advanced or metastatic pancreas cancer, and they did whole genome sequencing and RNA-seq of their tumors and classified them as either basal or classical on the levels of their gene expression, based on the levels of their gene expression, and then treated them with whatever, gemcitabine and Abraxane or FOLFIRINOX, one of the two, not based on those subtypes, but based on whatever they felt was the right thing to do for other reasons. But then they looked at whether they had classical or basal subtype. What they found was that a partial response to treatment, whatever the treatment was that they got, either gemcitabine and Abraxane or FOLFIRINOX, occurred in a third of the classical tumors, but only 8% of the basal tumors. And progressive disease, on the other hand, occurred in almost half of the basal tumors. So really, the classical tumors did well, regardless of what chemotherapy they got, and the basal tumors did terrible, regardless of what chemotherapy they got. And that was reflected in their overall survival. The overall survival of the patients who were treated, who had classical tumors, was 10 months, and the overall survival of the patients with basal tumors had an overall survival with 6 months. Interestingly, patients who had the best survival were those who were treated with FOLFIRINOX and had classical tumors, whereas the patients who had the worst survival were actually patients who were also treated with FOLFIRINOX but had basal tumors. So it basically causes you to wonder, should we be treating patients not on the basis of what their CAT scan looks like, but on the basis of their genetic alterations or gene expression profile? It is difficult, of course, to do all of these tests in the preoperative setting, the RNA-seq and the whole genome sequencing and things. But these authors also showed that simple immunohistochemistry for GATA6 was able to classify tumors. So if patients had high GATA6 expression on IHC, most of those were 97% of those were classical tumors. So basically, in theory, what you could do is, do an FNA or a core needle biopsy, do GATA6 expression, classify them as basal or classical, and then determine what treatment they should receive on that basis. And granted, we don't know exactly how to treat patients with classical and how to treat patients with basal, but what these data are clearly showing is that treatment probably should differ for these types of tumors. We also, we also know that in addition to thinking about what the anticipated natural history of a tumor is and how that should inform therapy, we should also tailor the duration and type of therapy to the extent that the tumor is responding to treatment. So, there's a lot of talk about giving total neoadjuvant therapy for 6 months and all this business. That's fantastic if your tumor is responding to the therapy. But if it isn't responding, you're just sitting there treating a patient with a drug that's not working for a long period of time and potentially denying that patient the opportunity for cure. So it's really important that we determine whether a patient's tumor is responding to therapy or not. Historically, we were able to only do that with removing the tumor. And, these are data from Anderson in which we looked at patients who had who received preoperative therapy, and then we took their tumors out, and then we looked at them under the microscope, and we classified them as either having a complete response or not a complete response. Patients who had a complete response or a near complete response did really well. Patients who had did not have a near complete response did pretty poorly. So that shows us that really we should be looking for response. The problem, of course, here is that it's not a real-time measure, meaning you can't kind of tailor the length of your therapy, your preoperative therapy, to response if you don't know what your response is until after you take out the tumor. So it's important that we monitor the therapy that we're giving while it's being given to see whether that therapy is working. And there's a number of ways we can do that. Here is some data from our good friend Gianpaolo, who looked at response in a couple papers while he was here at MD Anderson a few years ago. And what he showed was that there's actual value in looking at whether your tumor is shrinking. So if your tumor doesn't shrink, the likelihood of having a response in that group of patients, a significant pathologic response, is really low. It's about 5%. If your tumor shrinks, though, during therapy, the chance of having a major pathologic response in that group was 27%. So what does that tell you? It means that if your tumor is shrinking, that is good. It may not shrink, and that doesn't, you can't really say much if your tumor doesn't shrink, but if your tumor does shrink, that's a really good sign. And, if it were me and I was giving a patient chemotherapy and I gave that chemotherapy for 2 months and then saw that their tumor had gotten smaller, that would be an argument, at least in my opinion, to continue chemotherapy, because there's some correlation between tumor size and therapeutic response. We can also measure CA19-9. So these are data from our place, and there's other data from everywhere else now. But what this is basically showing is that if your tumor marker, your CA19-9, starts high and then falls into the normal range, that's good. If your tumor does not fall into the normal range, that's not so good. So when we treat, we like to treat and follow the CA19-9. And if the tumor marker is falling and the patient is tolerating the therapy, then we keep giving it. If we are treating and the patient is tolerating the therapy and the tumor is shrinking, then we keep giving it. If not, if the tumor is not shrinking or the tumor marker was high and is not falling, then that causes us to reevaluate the strategy and think, should we switch chemotherapy? Should we radiate? Should we operate? What else can we do? Because whatever we're doing now is just wasting time. There's also, of course, liquid biopsies that are being evaluated. Lots of different markers that can be identified in the blood to determine response. We've been looking a lot at exosomal DNA, and basically, if the fraction of mutant KRAS and exosomal DNA falls over the course of treatment, that's good. If it rises, that's not so good. And so, theoretically, at least you could envision a situation in which you measure some sort of circulating biomarker, you treat, you remeasure the biomarker. If the biomarker is dropping, then you keep treating. If not, then again, you either stop treatment and switch, or you move on to something else, or you operate, or you change your strategy. Again, you can't just, once you decide on the best treatment, you can't just stick with that treatment for 6 months and hope for the best. You have to monitor the results of the treatment that you're giving and then modulate the therapy based on those results. It used to be that we had none of these biomarkers, but increasingly we do. So I think, with respect to perioperative therapy, we need to change the questions that we're asking. The big question that everyone's asking, which is better for resectable pancreas cancer, pre-op or post-op therapy? I personally think that's a ridiculous question. I think there's patients who benefit from pre-op therapy, and I think there's patients who benefit from post-op therapy. And I feel pretty strongly about it. And, there are 2 ongoing trials right now. I think they're very great trials, and I think they're going to teach us quite a bit. But if these trials say that pre-op therapy is better, it won't convince me to treat everyone with pre-op therapy. Likewise, if it says that post-op therapy is better, it won't cause me to treat everyone with post-op therapy. I think you have to tailor the treatment for the individual patient. Which preoperative chemotherapy is best for resectable? Again, I think it's a meaningless question. We have to do better at figuring out what alterations may exist in the genome, what gene expression profile exists, how to best match those profiles and other phenotypes to the right treatment, and then follow that treatment with markers of response. Is there a role for pre-op RT for localized pancreas cancer? I strongly believe that there is, just not for everybody. So we used to use radiation here for every patient with localized pancreas cancer. Now we use it for about 50% of patients. So, one size does not fit all for patients who share an anatomic phenotype. So, I think a massive conceptual shift is necessary for us to improve the health span and lifespan of patients with pancreas cancer. Yes, staging is important. Tumor anatomy, super important. We've done a lot of work over the past 3 decades in terms of tumor anatomy and staging, and I definitely think all that work still has relevance, but it has to be put into context in terms of the patient's tumor and in terms of their physiologic status and in terms of their individualized response to therapy. And we need to put all that together when we're developing preoperative or postoperative, perioperative treatment plans for these patients. This is part of MD Anderson here. This is all the Texas Medical Center. Basically, as far as the eye can see, this is all Texas Medical Center. This here in the distance here is Houston. But this is some of the Texas Medical Center, which is basically another whole city of hospitals. We have Francesco here now. We had Dr. Perry, Gianpaolo here before, and I'd be thrilled to continue this relationship with you guys in Padua. I think it's fantastic, and you're all welcome to it. So thanks very much.
Thank you very much, Dr. Katz. It was really, I would say, comprehensive and a great lecture. So I would really love to ask you a couple of questions just for the sake of the debate, even though some points were absolutely clear. And I really loved actually how you started the discussion from the mouse modeling that really elucidate the rationale for preoperative chemotherapy and the non-sequential growing of pancreatic cancer. I mean, I really think that this, in a pictorial way, really, frames why there is always, this sort of also philosophical need to integrate chemotherapy and surgery. But as you said, I mean, we are surgeons, and sometimes we face these cases. And in the strive of a more personalized approach, what would you do whenever oncologists define a resectable cancer as I would say, I will put into brackets, unfit for chemo, but the patient is indeed somehow fit for surgery? This is something that really, I mean, on this side of the ocean, becomes sort of a fight at MDTs, because for some reason, some patients are defined as not eligible, to get high quality chemotherapy, but that in your hand, mainly because of prehabilitation, as you showed, the Whipple is, so to say, not impossible. So is there any rationale in operating? Are we providing any benefit to this patient if we go to surgery?
Yeah, I think there are very few, if any, patients that are healthy enough for surgery but not healthy enough for chemotherapy. I can't personally think of a situation in which I would operate on someone that I wouldn't, give some chemotherapy to. So I think that's, I think that you need to push back on that. Now, that being said, there are certainly patients who aren't fit for either. So just because someone is not fit for chemotherapy doesn't mean that they're fit for surgery either. Now, it doesn't mean that I would necessarily refuse them surgery, but I would certainly delay their surgery until such time as I felt comfortable to do it. So, there are lots of patients for whom, for example, well, maybe not a lot, but there are certainly patients who the medical oncologists say, well, I can't really treat with chemo. Why don't you operate? And I say, absolutely not. I'm not going to operate. However, I'm going to send them to my nutritionist, and I'm going to send them to my prehab people. And it may take a month. It may take 2 months. It may take 6 months. And whatever it takes, I refuse to operate on people until I think that they are going to, uh, not only survive the operation, but be in a condition to receive the chemotherapy afterwards. I showed the first slide I showed the results uh, of uh, of I'm trying to share. Uh, I don't know. Well, at any rate, the first slide I showed, this shows what happens when you operate on people and they don't get chemotherapy afterwards. They live about a year. They recur within like 9 months. So if you take a patient that can't get chemo and then you operate on them, I mean, they may struggle through, but they're still not going to get chemo afterwards. So then where are you left? You're left with a patient who basically struggled through an operation and then doesn't get chemo and then progresses anyway. So I'm sure there are patients who you can get lucky with, but by and large, if they're not healthy enough for chemo, they're not healthy enough for surgery, in my view.
Clear point. Yeah. Okay. Thank you for providing such a very, I would say, clear statement. Are there any other question or comments from the audience? We can still, I think, another couple of minutes to Dr. Katz, and then we have to close it. You pointed out very well that, I mean, we have trials, of course, and we always look for the evidence coming from trials. And as you can imagine, in Europe, there has been a lot of debate after the NORPAC the trial was released. And I mean, honestly, from a surgical standpoint, I don't think we should just commend the trial that it was, as it was said, poorly carried out, because still it delivers a message, I think. And you pointed out that there are indeed some patients benefiting from surgery, even up front, as long as they can get chemotherapy after. Can I add this to your statement? So
that's right.
Yeah. So please.
Sorry. Yeah, we treat. I think everyone associates our place with pre-op therapy, and that's fine. But historically, and unchanged over the years, 20% of our patients undergo surgery first, 20% with pancreas cancer. But those are patients, exactly like you said, healthy, typically young, typically skinny. I'm sorry, but it's true. Typically normal CA19-9, anatomic tumor that is anatomically resectable. Basically, tumors and patients who we anticipate will recover well enough to get therapy afterwards. And if you meet all those criteria, I have no problem operating on you first. And in fact, that's actually my preference a lot of the time.
Again, very, very, very clear answer. And also, I mean, I'm not asking you again any comments on radiotherapy, because I mean, you were again, clear in say that it's unclear. What is
Unclear.
it exactly? But I mean, yeah. Do you think that we're gonna in the end make the point, regarding radiotherapy, or probably it's gonna shift towards probably the non-operable setting, as a weapon to stabilize disease, or there is going to be another season for the intraoperative radiotherapy, which was kind of on the rise some 10 years ago. But I mean, it's really puzzling, right? I mean, how the evidence is sort of like.
But the evidence, I think the problem is, I believe that preoperative radiation therapy helps certain people. Again, the problem is not, the problem is the way we're designing these studies, which is to say, take all patients who have X anatomic stage and treat them with radiation, and then look at their survival. I just cannot imagine. I think you are going to be able to change the grays and the length and all the things and the way you draw the circles and all that stuff. And I don't think it's ever going to change and improve survival. However, if you look at more defined categories of patients based on other things, likelihood of progression distantly, maybe their gene expression profile, I don't know. maybe their CA19-9 level, or look at different endpoints which may be meaningful, local recurrence, time to progression, all that stuff, then I think there absolutely are going to be patients who benefit. So it just depends on how we define benefit and who we look for benefit in. But if we keep running the same trials that we keep running, we're never gonna see it.
Absolutely. I think that's the best closure of this great lecture. So, Dr. Katz, thank you so much once again. I think I will go back to see this video again to, keep learning from it and also to get new ideas for additional studies, hopefully together. Once again, thank you so much. And I would like also to thank all the audience, and I will see you next month with another guest, to this fantastic meeting. Thank you again from Padua to Houston all the way, and see you soon. Bye-bye.
Thanks so much. Bye.